Hello, everyone. Welcome back to the Surfside Recovery Podcast. My name is Brian Licata, and we just wanted to let you guys know that if you or anyone is struggling with addiction, to please reach out to Surfside. You can give us a call at 609-709-4205 or visit us at surfside.org and all of our social media platforms. Hello, everyone, and good morning. Welcome to another episode of the Surfside Recovery Podcast. I'm Brian Licata here with my favorite coach, Alyssa, or Alyssa Fountain, if you prefer. This is the favorite of the two. We have a very special guest today, and I'm going to toss it over to Alyssa to introduce that guest. Go ahead, Alyssa.
Hi, good morning. Okay, so I am super excited to be the favorite coach, first of all. Today, we have Dr. Kristen Mazoki on the podcast. Kristen is a psychiatrist, and funny story, I realized who she was because I was going to CrossFit with her husband, Phil, and I saw his name on the sign-in sheet one day, and I thought, oh, that's so funny. I wonder if he's related to the Dr. Mazoki who does the H&Ps that get faxed over to me sometimes when people needed inpatient residential treatment after, some stabilization at one of the local hospitals. And I asked him, and he said, yes, indeed. His wife is a psychiatrist who's focusing specifically on addiction. So in our very small worlds, she and I were connected. But Kristen, do you want to introduce yourself? Tell us who you are, how you landed, where you've landed, how you came to be in Ocean City, New Jersey, of all places, and some of what your specialties are.
Sure. So I don't know if I can technically call myself a full psychiatrist yet because I'm in my 4th year of training residency. So my 8-year total of postgraduate training. It's a pretty freaking long slog. So I'm a 4th year psychiatry resident at Cooper right now. I work at Cooper as well as Atlanticare. Basically, I went to medical school in Maine, but I'm from the Philly area. Prior to med school, I was a substance abuse nurse in Philly, and it's kind of been part of my interest for a long time. And when I was choosing a residency, it was important to me to find a place that, needed help. Atlantic City and Camden certainly both fit that bill. And also my family's here. So my mom moved down the shore when I graduated high school. So my mom was down here, and I love the beach. I'm sure everyone on this podcast and people that are in your circle, Alyssa, certainly know that you need to find the zen in your day, right? When you're working with people who are really sick and struggling, you need to fill your own cup or else you're going to lose your mind. So that's kind of why I'm in Ocean City now. It's a little strange. Ocean City is a little bit of a strange place, but I like the beach a lot. So, and I got to meet you, so that's cool.
Yeah, I was super happy that Surfside was located where it was because it meant that I got to move down to a beach house. It was funny when my dad was driving me down. He was like, "This is messed up." He's like, "You keep screwing around, and I've been working for 30 years, and you moved to the beach before I did." So that's just the luck of the draw, though.
Yeah.
So Kristen, what I want to know from you, we can kind of talk about all sorts of stuff, but you're like, you're young in the field of psychiatry, and I met some of the other residents who were at that 3rd year of residency party that I went to a wedding, and Kristen was telling me that she was having a party for her 3rd year of residency, so I showed up. And it was great, but I met a bunch of you, and you're young, and it seems like a lot of your peers have kind of like a zest for the work that you do. So my thought is kind of like, what do you think that this newer generation of folks studying psychiatry are bringing to the table? Do you feel like it's changing the game at all, or do you feel like there are people bringing new passions that maybe we haven't seen before?
Yeah, so it's definitely a case by case. I don't want to speak for all young new psychiatrists, but I think a lot of the people going into it now have some skin in the game. There's a reason that they're in it. In the past, psychiatry was could sometimes be, not all the time, could sometimes be like a landing ground that you kind of got there. You're not sure exactly how you got there, but pretty much everyone I know now has pretty good reasons for choosing this field and a lot of personal experience going into it. I myself have never met anyone whose life was not touched by depression, anxiety, or addiction like ever in my life. So I think everyone would have a little bit of skin in the game, but the people that are going into it now kind of really give a shit. Can I say shit? Okay.
Whatever you
They
want.
Yeah, you can say absolutely whatever you want.
they really do. And you know, we're hopefully a grittier, kind of more down to earth world. Psychiatry was very much like a academic, like couch. You think of Freud, right? Like you think of the guy with the pipe and like you're laying on a couch, and it was very much like the psychiatrist and then you, and like, not that of course there's boundaries in every relationship, but I am very much about the community. I this past year was in charge of the residents in the state of New Jersey at all the different programs for our branch, New Jersey Psychiatric Association. And I can assure you from what I've seen there that we are interested in community involvement and like being more involved with community, like organizations like NAMI, getting out there and being seen and being like, hi, I'm like a doctor person and you can chat with me and and like no worries. So that's kind of what I'm about, and I have seen a lot more of that. And not that we don't do research, like we still do tons of nerdy research and are reading textbooks and like that kind of crap. Like, I mean, we're still doing that, but and community psychiatry has gotten really big, and that's about community outreach and empowering communities and realizing that that's the key. Not coming to see a psychiatrist once a week for the rest of your life. Like the key is trying to help people tune up their mental health so that they can then have it more functioning and then can bring more functioning to their community.
Interesting. Can you talk more about that?
Sure. So like IPS is a branch of the American Psychiatric Association, and that's the Institute of Psychiatric Services. And if you ever feel like browsing around, it's very cool. It's all about things like assertive community treatment, which are ACT teams. If you've never heard of an ACT team, they basically go out and they try to prevent you from hospitalization and prevent you from going to jail, because as you guys probably know, jails and prisons are the #1 provider of mental health in this country in an alarming, that's another podcast, right? So I won't.
It's a really weird way to like think about it. Is that, yeah, that's very strange.
Yeah, it's true.
It's very strange.
It's true though, and it's not always the best mental health care, if you could imagine that. So anyway, and then the American Academy of Community Psychiatrists, which is actually, the meeting's going to be in Philly this year in October. They're even having fellowships now. Like you can do an extra year to learn how to be more engaged and more helpful in your community. There's one at Penn. And the guy that runs it, I was able to do rotation with in Philly in my 4th year of med school with the Department of Behavioral Health for the city of Philly. And it was just so interesting to have a recovery-oriented model, is what, not just for addiction, but for all of mental health. That's the movement. That's the community movement, is a recovery-oriented model and finding health, right? Not focusing on the illness and did you take your meds? Are you hearing voices, right? But the actually like, oh, well, looks like you went for a walk today. Good for you. Tell me about your walk. Did you see a tree? Did you see a dog? You know, so that's kind of the movement. That's what I believe in. I could talk about this forever. I really like this stuff.
I love it. And we've talked, we've gone for walks and talked about health and moving your body. And like, I was telling Kristen about how when I first got sober, I would be like, yeah, it's great. My insomnia is crazy. And people were like, no, you're drinking 2 cups of coffee and an 8 p.m. 12-step meeting. You're not an insomniac. Like everything that you put into your body actually has an effect. So I think that that's kind of neat. And Like, is there stuff that you would want to say to someone who is maybe in early recovery, coming off substances, about like where their mind is and other healthy behaviors they can engage in?
Sure. I think so. When people are in early recovery, I first of all always recommend peer support, right? And people that know what's up and know what they're going through. And then as the role of their physician, I try to kind of support them while they try to get their shit together, right? I'm just like, hey, I'm here for you. I'll see you however frequently you want to see me. You want to do a little meds, cool. You don't want to do any meds, cool. But I'm going to be here supporting your physical and mental health while you figure out what it is you need to do to, begin your recovery journey, right? So, but some things I always talk about, I mean, sleep is huge, but it really takes, and I'm probably telling you guys are like, yeah, duh, I know this, but it takes about 6 months for your circadian rhythms to stabilize after you're in substance use for a while, for most drugs.
Yeah, that sounds about right.
Yeah. So it really, like 6 months into your recovery before you can expect to see like your full beautiful sleep, if you ever had full beautiful sleep to begin with, because I have plenty of people who do not use any substances and still can't sleep, so that's something to work on too. Sleep is huge, and what you're putting in your body is huge. So before I am going to give someone a pill, I want to talk about, I would like to see, people don't like this, I would like to see a 3-day diet journal and like at least like a week-long sleep journal, and see like, okay, well, no, but actually, how much time are you in bed? How much time are you sleeping? Really having data, right? I know that's a doctory thing, but having data is good, because if you just feel like your sleep is crappy, but you can't really quantify it, then it's harder for your physician to help you figure it out and sort it out. So I think gathering some data for yourself, and then being really honest about caffeine intake. And I mean, people walk into my office with Monster energy beverages and will say, I just really can't sleep. And I'm like, well, this is a 4 p.m. visit, and I see you have that Monster there. So I'm just curious why that was your choice. So maybe we can make a different choice next time. And then like focusing on choice by choice too, like make a better choice. We have a friend, Alyssa, you know what friend I'm talking about, who will tell her kids, can you make a better choice? And it's like moment by moment like that. So, and then I don't try to harass people too much in early recovery about their caffeine consumption, because that's not well received. However, caffeine is also a substance, right? So in the DSM, which is our Bible, right, our DSM-5, that's the Diagnostic and Statistical Manual for psychiatrists, how we label people. Again, that's a separate episode, because I have issues with the DSM. But there are 11 substance use disorders that you can have, right? And one of them is caffeine. Caffeine use disorder is in the DSM, right? So just the thing. And it's the same criteria as opioid use disorder or as alcohol use disorder. Are you seeking caffeine all the time? You try to limit it, but you can't, it's the same criteria. So I kind of sneak that in usually to people as they're seeing me. Like I'll just like kind of tuck it in. And I'm big, and I always address smoking too. Always. Most of the studies have shown, again, I'm not a smoker, I've never been a smoker, but most of the studies have shown that you will do better if you quit both at once, right? And that is something that people, did I go away? Oh, that is something.
Yeah, you're good.
People really don't like to hear. But I went to a great lecture once with a pulmonologist, and he was seeing a lot of people in the ICU, right? So ICU, if you have an opioid overdose, you might wind up intubated in the ICU, right? And then you're smoking too. And he's like, isn't this a great time to quit smoking so that I could save your life better and you can breathe better? Should I need to resuscitate you again? Right? So I bring up smoking too. And it usually takes about 10 times before someone even listens when I bring up smoking.
Oh, wow. It's funny that you mentioned smoking, because there was some real controversy I can't remember if it was just Philadelphia or all of Pennsylvania. I want to say it was Pennsylvania as a whole, but treatment centers banned smoking And it was really interesting because as someone who has worked in treatment, like usually the question number 1 or 2 is, can I smoke while I'm in treatment?
Mm-hmm.
So it's this major barrier for someone entering treatment. But the statistics show that when people, like you just said, when people quit smoking at the same time, statistically, there's a lot more success in abstaining.
Yeah. And
Yeah, they banned smoking in New Jersey treatment centers. I want to say it was like in 2014. It didn't last that long, but they had it there for maybe like 5 or 6 months. But I called to go to a place, and they told me that they weren't, like, you couldn't smoke there anymore. So I decided not to go, and then just kind of waited around until you could smoke there again.
Yeah, and that's what like a lot of folks were talking about, was it's this huge barrier for someone to enter treatment, but the success is going to be so much better. So it's like, which one do you pick? Or the success could be better. It's not necessarily right. It's how you measure success. And
well, here's something, and this is something I'd more posit to you guys. Do you feel that someone is really ready to begin their recovery if smoking is that important? I don't know. I don't have that answer to that, but like, you're ready to fully commit to not dying by overdose, but you must smoke, so maybe not. I don't know. Just a thought.
oof, I we'll leave that as a rhetorical question.
It's a rhetorical question, but I mean, that's something that I think about, because it takes a lot of time for a lot of people to figure out what their recipe for recovery is, right? So maybe if the smoking is the thing that maybe it wasn't your recipe for recovery time, because that place wouldn't let you smoke. Maybe it just wasn't your time yet. I don't know. But yeah, and then I will also talk a little bit about getting the proper nutrition. Not like any fancy nutrition stuff, not like CrossFit-y, like real nutrition stuff. Just my nutrition counseling. You guys, listen, I was real naive when I started. I used to have this whole spiel. Forget it. Now I say, when is the last time you ate a vegetable? That is my nutrition counseling. And do you know the number of people? I mean, people aren't taking care of themselves when they're in the throes of, this issue. So they will say, that's a really good question. I have no idea. So that's where do you think
the peppers and onions on top of a pizza count?
No. But I mean, that is a perfect response for what I would get, right? Like, people will say stuff like that. Well, I think when I was at, Popeyes or Chick-fil-A the other day, I think, what about the French fries? Potato, does that count? So that's a good start too. Like, could you eat one vegetable per day? Do you think that's possible? So I'm kind of engaged with that. I feel like I have so much to talk about, Alyssa. Like, can we make like a little sheet for next time to guide me? Because I have so many things.
We can have like recurring episodes with Dr. Mazoki.
Yeah, and if anyone that's listening has questions or something that they want to, or a bone to pick with psychiatrists, bring it on. I'll come back and I'll do it. I'll talk about that.
I love.
So I have a question. Like, so how do you see like your role as a psychiatrist work together with like somebody who's in a 12-step program and like sponsorship and things like that?
So I'm very glad that you asked that, because this has been really challenging in my early young career, because there are a lot of 12-step programs that preach that you should have nothing, no substances of any kind, including medication, right? So I will give you a story, and I hope this sinks in for some of the 12-step programs that can be a little bit intrusive about this kind of belief or methodology or whatever. I have a patient who, has not just substance use disorders, has other disorders, like very, very SMI. SMI means serious mental illness, right? So we have a couple different diseases that will kind of qualify for SMI. And this patient was someone who was in recovery for about 5 years, but has serious mental illness, went to a new 12-step program who recommended no drugs, right, of any kind. So went off her medications for very serious mental illness and has been completely decompensated since, back in the hospital, lost her job. This is a serious thing for some people, right? You know, we talk about, in psychiatry, we talk a lot about comorbid versus like substance use versus is it comorbid? Well, my personal, again, just speaking me, I have never met someone with a substance use disorder who does not have a comorbid psychiatric condition, whether it be anxiety, depression, and gold star, triple gold star trauma, right? So much trauma. So for me, the 12-step programs are so wonderful, right? I used to get in arguments with this old school AA guy at the VA, and he would make me go to all these different meetings, and I would go to the meetings, and he'd be like, doctors have no business in recovery. Doctors, you're just another drug dealer. And, you know, and he and we've done so much, you know, battle that I feel like I have my responses prepared for when I get, but I beg anyone listening, please, there are some people who very much need medication. And I am not a doctor who wants to give out medication. I don't love it. It's not my favorite, right? I'd rather send you on a hike or, you know, eat some freaking kale or whatever. But this is life-saving medication for some people. So that is my bit with the 12-step program now. I ask people what they're doing. You know, when people are like, oh, I've been in recovery for 5 years, I'm like, great, tell me exactly what you did so I can share it with everyone. Because I don't actually know, right? Yeah. So I don't know if that answers your question, but I was hoping I would get to squeeze that in there.
Yeah, no, definitely. Yeah, the thing that I see is kind of something similar to what you said. Is there's either this, you know, there's like a sect of people that, you know, don't think you should be on any sort of medication at all, which is like pretty dangerous, you know, because you have people who, you know, been sober for a couple of years that don't have any like medical training or anything like that, trying to tell you what you should do about your meds. You know what I mean?
Right.
And, you know, I've seen people that I care about, you know, go off their meds and it not like end well because, you know, they were listening to people who have no idea what they're talking about. But on the other side of the coin, like you were talking about before with like, you know, caffeine intake and stuff like that. Like I see a lot of people who are in the rooms who take way too much medication. And that of course is like my, you know, you know, I don't have a doctorate degree, you know, I don't know if they're taking too much medicine at all, but like, you know, I talk to kids and they're like, well, you know, I'm taking this one pill and then it's doing this. So I'm taking another pill to counteract the side effect of that. And then another pill to counteract the side effect of that. And it's like, well, maybe if you just didn't take any of them, you wouldn't have any of the issues that you're having, you know, but
and then
you know, that
we get into that too. I'm sorry if I interrupted you, but I see that.
No, go for it.
And I go for like one med. Let's tune up one med. Let's try it. That doesn't work. Then we quit it and we try a different med, right? We don't want polypharmacy. We want one medicine if you need one medicine, and then maybe you won't need that medicine either. But I mean, the side effect burden of a lot of the meds I give are no joke. What happens is sometimes people with substance use disorders actually like taking pills. I'm sure that's not a shock to you guys, right? So
yeah, no, not at all. I mean, you know, and that's the thing I see with those people who are taking like way too many pills is like they think just because they take it, it's gonna, you know, solve whatever problem that they have.
Yeah. So that's something that when I inherit patients, it gets very tricky because people are not thrilled when I'm taking things away from them, which
Right.
is usually what I am left with sometimes. Someone who's a young guy who's, you know, in recovery on 4 medicines, and I'm like, oh, well, all right, well, maybe we can reduce this one, and then I get eyes, right? So I have to kind of establish that rapport first and get someone's buy-in to me. They need to like buy into me before I'm going to be able to touch their meds. But I am cleaning up messy medication regimens all the time. And I have to say there are a lot of them. And I'm hoping that as we move forward in psychiatry and become a little more holistic, a little more community oriented, maybe someday like actual nutrition will be supported by the government. Again, we could talk about the government and psychiatry someday too. But then maybe we can move forward and we won't have that much messiness. But yeah, I mean, I see it both ways. I really do. I get both. The people that are like AA people that are like, I can't sleep and I haven't slept in years, but I can't take anything. And you're like, okay. And then the people who are like, I need all 5 of my medicines and increase them.
Yeah, I know. I mean, I've talked to people off and on for years who it's like you can show up sometimes to a 12-step fellowship and you've got 7 different diagnoses, and you've never actually tried to be without a substance. So it's like, do I have ADHD and OCD and generalized anxiety disorder and also potentially bipolar disorder and a personality disorder? Or have I been using substances for so long that it looks like everything? Because that's all what I was diagnosed with. But what's crazy is like, then kind of what you guys have talked about is like, I know people who at 2-3 years without a substance and maybe without medications are sort of like, okay, now I know something is not right here.
Yeah.
And, I think we run into very often, Brian, you would agree with me, that sometimes it's like, a higher power can help a lot of things, but it doesn't necessarily cure mental illness. There's only so much that we can pray
Right.
depression away or mania.
Yeah.
I don't know that mania is actually like the clinical term now, but
No, it is. But no, you're right. And listen, when I have people, any patient, not just substance use disorder, if they're telling me about Jesus or exercise, I'm like, great, you have Jesus, you have exercise. They are some of the best, like, sure, that is going to carry you a long way. And this is my, and then I do have to go because my friend's going to kill me. But this is what I tell everyone. Everything is 10%, right? Everything that I tell you or give you or help you with is 10%. So if I give you a medicine for your depression, that's going to help you 10%. That's it. Right. And then if you do sleep hygiene and you treat yourself well in the evenings and start to try, that'll be 10%. And then if you start an exercise program, you take a walk every day, that's 10%. Then you eat a vegetable, that's 10%. So now we're at 40%, guys. We're 40% better, right? So everything is 10%. And that's a tough concept for some people, but it mitigates expectations, right? So you need to find the things in your life that get you to like 80 or 90, but it's not going to be one thing. So that's an important message too. And it's not one that everyone loves, but my 10% rule it's true. And then we pick things and I'm like, oh my gosh, we're up to 40%. Look at you, like not too far to go. Woohoo. Right. So yeah.
Well, you're a great cheerleader, and I know that you have yoga on the beach with
I do.
Tess. Shout out to Tess.
Yeah.
All right, Brian, I'm kicking it to you.
All right. Very good. Dr. Mazoki, thank you for joining us today. If someone wants to get a hold of you or find more stuff out about you, how would they go about doing that?
I am at Shrinks and Sneakers. That's me and my co-resident, Garrett Rossi. And it's shrinksandsneakers.com. Catchy little name, right? Try to make us seem more approachable wearing sneakers, although I have Crocs on right now in the interest of this.
Awesome. Well, thank you so much for your time. We really appreciate it. And it was some good information. Hopefully we'll have you back sometime soon. Enjoy your yoga class on the beach.
All right. Sounds good, guys. Thank you.
Thanks, Kristen.
Adios. And until next week, thank you very much.
As always, if you or someone you know is struggling, please reach out to Surfside. You can give us a call at 609-709-4205 or get us on the web at surfside.org.